Hey everybody, welcome back to the ECG of the day. My name is Reed. Don't forget to go into the description and download the PDF of today's EKG so that you could follow along and make your own notes. And while you're there, feel free to like and subscribe if you enjoy the content. Let's get rolling. So first we're going to just start by looking at this EKG and look at the forest. And the trees of the forest are our QRSs. And so this is it's a pretty funky EKG, as you can see already. We've got these narrow complex QRSs. We've got these funky beats, which I'll arrow in red here, that seem to not match the normal pattern. Even this one is funky, of our narrow complex QRSs, and you can tell that it's not a perfectly regular rhythm. This is a pretty narrow R to R interval. Compare that to some of the others. So maybe regular, maybe not so regular. We'll find out. We'll kind of suss that out here in a little bit. And so when I look now and see I got narrow QRSs, so my narrow QRSs makes me think, yeah, this is probably coming from the AV node. And let's see what's going on. I see we have atrial activity in the form of P waves here in lead 1. But when I look in front of my P waves, I do notice that in lead 2, I've got these pacing spikes. And so pacing spikes that occur in front of P waves, that is an atrial pacing. So that means that this person's got some wire that's attached to, say, this pacemaker that is at least in the atria. So they've got a pacing wire in their atria. Most likely that means they've got a pacing wire in their ventricles, and we're going to figure that out. So we've got atrial pacing, and if you look through, it seems like atrial pacing is occurring quite frequently. And so now we can see let's just talk through what should we expect after we see an atrial pacing spike. So we get an atrial pacing spike, we get our P wave, which occurs, as you can see, right after the pacing spike. That tells me that the atria depolarized just after the pacing spike. And then we get a narrow complex QRS without a pacing spike. I don't see pacing spikes in front of these QRSs, and so that tells me that this is atrial pacing, but our AV node is functioning, right? So in this case, this person needs an atrial pacemaker because their SA node is not firing off, so the atrial pacing wire does it for the heart. Well, this person has an intact AV node to a pretty good degree. You can see our PR interval is a little bit long, but just a hair long. This person's AV node generally is functioning well. And so we can say that this person is in the mode of what we would call our mode. We need to figure out what mode is this person in. They are atrial paced ventricle sensed. So what that means is that this person has a pacing wire in their atria, and they've got another pacing wire in their ventricles. And the atria pacing wire is firing off when the SA node doesn't fire, and it depolarizes here. But this person has a functional AV node, and so when the AV node sends the signal down and causes that narrow QRS depolarization, the ventricular pacing wire senses that. It can sense that electrical depolarization, and it says, okay, I don't need to fire off. And so that's what we're seeing here. And so let's explain the rest of our EKG and what's going on. So notice here, I've got this right here is a narrow QRS, and then I've got my pacing spike, narrow QRS, that occurs again. And then I have what appears to be an early beat if I look at my R to R interval. So this one is early. And why is it early? And if I look closely at the P wave, my P wave looks a little bit different. Look at the P wave here. Look at the P wave here. Compare that to the previous P waves. Compare that to the previous P waves. These P waves have no pacing spike, and the morphology is different. So this P wave, really it looks like a sinus P wave. So this, to me, is a sinus P wave that conducted normally to the ventricles. So this beat was from a sinus P wave, so we've got that. And then this next funky beat with this red arrow that we said we were going to discuss, this is a wide QRS, right? If we measure that out, that QRS is greater than 120 milliseconds. it looks pretty early. And I have to look at what I need to do is I need to look in detail in front of it and make sure that this is not a PAC with aberrant conduction. And I don't see any P waves, right? Do you see any P waves here? Because I don't. I see a nice T wave that when compared to previous T waves looks the exact same. So this is a wide QRS in the setting of no atrial activity before it. This is a premature ventricular contraction. And then after our PVC, we see the resumption of our paced P waves that conduct nice to our QRS. Then I've got another funky beat here that closely resembles our previous PVC, and if you look, it's the same wide complex QRS with no P waves in front of it, so we have another PVC here. Our next beat is kind of a funky beat. If you notice, we've got our paced atria, and then it looks like we've got our paced ventricle. So I think what we're seeing here is a fusion. I always spell fusion wrong. I think it's just one S. Fusion beat. What a fusion beat is when you have a ventricular paced beat at the same time as the normal QRS that's going through. So it's like a merging. So like it would be if this person here, their atria depolarize, so the atria depolarize is like normal. The AV node takes the signal, starts to depolarize normally, but the pacemaker fires off at the same time. And so you get a fusion beat where these two kind of areas of depolarization, they come and fuse together. So you get a little bit of a funky QRS. So I would say in the setting of a pacing spike and a funky looking QRS that's not perfectly wide, like a ventricularly paced beat, we can probably say that's a fusion beat. And similarly, I would say that this funky beat that we said with our red arrow here, I would say this might be a fusion beat too, in the sense that if you look at our QRS, it is wide, but it's not as wide as our previous premature ventricular contractions, but it almost looks like there's a little bit of a notched, right at the end of that QRS, or excuse me, at the end of that T wave, that looks like that could be a P wave that's just peeking out. And that P wave conducts, and so likely this is a fusion between a PVC, right, because it kind of looks similar in morphology to our previous PVCs, but it's a fusion between a PVC and a normal QRS. That's why it's a little bit more narrow and a little bit less dramatic. And then we have the resumption again here of our atrial paste, and then we have another sinus P wave. So that explains when these sinus P waves occur, they conduct nicely to the ventricles. And so this person, generally, their pacemaker mode is atrial paced ventricular sensed. There are still rare sinus Ps that conduct to the QRS, and there are also some premature ventricular contractions. Remember, when you're looking at premature ventricular contractions, you need to exclude P waves or atrial activities before to make sure that there is no atrial activity driving that QRS. Just like in this fusion beat, we had to really compare the previous PVCs to this, and we had to look in front of the QRS here to make sure, and we did find a little bit of a difference in the way that T wave looked that would make sense with how our SA node or our atria was depolarizing. And so this person has a dual chamber pacemaker. Their atria is being paced for the most part. They've got a couple premature ventricular contractions. And so, yeah, this person's got some crazy aberrancy going on when you look through their QRSs, but that's okay. They're in a perfusing rhythm here, and I don't see any crazy ST segment changes, T wave abnormalities that is really indicative of this person having any major acute ischemia. And so I hope this helps you better understand these rhythms, and if you have any questions, throw them in the comments below. Thanks.